So over the past 6 weeks, we've discussed a myriad of topics and disorders that are described in the DSM-5-TR. And then we get to week 6, the last week of the course. And all of a sudden it feels like the disorders and the topics that we're talking about, they just don't fit in together nicely. Or maybe it's just that they don't fit in obviously together. So when we've talked about depression and bipolar disorder, we can see the similarities there. And really, as a provider or a clinician, that's where we get to start looking at the symptoms or the symptomology and get to distinguish which one does a client, patient fall into. But this week we're talking about almost seems like 4 different disorder topics, and that's sexual disorders and dysfunctions, body and gender dysphorias, conduct disorders centered around externalization conducts, and substance abuse disorders. And it's almost like, how do they fit together? But I think they do. And I'm going to try and put it all into a bow at the very end. But let's jump in and let's start talking about sexual disorders and dysfunction. So part of this is we're going to look at 2 separate pieces. So we have sexual disorders, and then we have what we call paraphilic disorders. So sexual disorders are more associated with how a person responds to sexual interactions, whereas paraphilic or paraphilia is more about how a person responds to their own non-conventional desires, which oftentimes are also non-consenting desires, meaning that often other individuals or the other individual involved in a person's fantasy typically doesn't want to be, or maybe they had no choice in it, or maybe they don't even know what's going on at all. And this is where we start getting into the place where we distinguish what is paraphilia. And typically with paraphilia disorders, there are things that we, in our country, the U.S. specifically, we would say these are violation of other people's rights. But what's interesting is there's a piece to the puzzle in both sexual disorders and paraphilia that I would be remiss if I didn't draw the conclusions together, specifically around pornography. So a 2022 study by Cray et al. Found that pornography is linked to sexual aggression and victimization. So when we talked about paraphilia or paraphilic disorders, that's what we're seeing. We're seeing sexual aggression in people and the obvious victimization of people when we look at voyeurism and things of that nature, or sadism, where people are literally finding sexual desire in people having like pain during the sexual intercourse, or even when people aren't being in a sexual interaction. And what's interesting is pornography is what we are seeing as a link to the progression or the exacerbation of these sexual aggressions. Another piece of that puzzle is Rowland and Cooper, 2024, found that people with erectile dysfunction are linked to a higher pornography addiction. So they're more likely to be addicted to pornography, those with erectile dysfunctions. And now the erectile dysfunction is one of those pieces that we see in the sexual dysfunction disorder piece, whereas they might feel shame and guilt or even depression that comes along with the symptoms of erectile dysfunction. And it's pretty interesting how that works out. And there's also another piece of this puzzle that the masturbatory guilt, and some guilt and masturbation, has been seen to lead to depression and other disorders centered around guilt, shame, and a lack of self-worth, according to Aneha et al. 2015. So it's like all of these pieces of sexual voyeurism, of pornography, we see them putting into play, and it all just kind of gets centered into this one place of guilt, shame, and so forth. In her book, The Great Sex Rescue, author Sheila Ray Gregoire describes how sexual shame and guilt can cause sexual dysfunction. And it found a significant link between sexual shame and even church trauma. Not necessarily that they had sex in church or that they were violated in a church, but from the perspective of, especially in some parts of the Christian religion, where they mention to women, hey, women, it's your job when you're younger to always say no. A man's going to do what he wants to do if you let him, but it's your job to not let him. But when a woman gets married, what's the opposite of that they hear? It's when a man wants sex, you give it to him. So you can understand the mindset and the shame and the guilt that might come along with a female in this, where she was once told it's your job not to do it because a man's going to want it no matter what. And now when she gets married, hey, you got to give it to him whenever he wants. You can see how this just doesn't align very well and can create this issue within females. So this other portion that we talked about was in conduct disorders, or specifically externalization disorders like ODD, conduct disorders, intermittent explosive disorder, and disrupted mood dysregulation disorder. So now all four of these have a piece of it, and it's what we call, if you think of the acronym, every child is special, where the E stands for emotions, C is consistency, I intentions, and S being severity. So an ODD, or oppositional defiance disorder, it's very emotional. And it's consistent in behavior and very intentionalized, where ODD is specific to people or children that are oppositional defiant to authorities. And a lot of times, hey, my son is actually ADHD, oppositional defiant, and he gets along great with teachers and other authority members. But when it comes to mom and dad and sometimes other family, it's like, what are you doing, kid? Like, can we please just have a calm night? But hey, it's just something that he goes through. But the severity of it is not necessarily as exaggerated or extravagant as other external disorders. But I think of this, I think about what it is. It's a person, it's my son, who really, really, really likes to get under my skin. Really, really likes to get under my skin. But he doesn't have conduct disorder. Now, if we look at conduct disorder, it's kind of like ODD. It's consistent, it's purposeful, and it does have some things to do with emotion, but where it differs from ODD significantly is in its severity. Specifically, it goes beyond just being intentionally disobedient, and it starts to get crossover into that super annoying to where it's disrupting of other people's rights. So this is where maybe they're stealing, or maybe they're doing something intentionally, or hurting something, bullying, fighting, those type of things. That's what we see more in conduct disorder. And interesting enough, it's not uncommon for people or kids with ADHD kids that have ADHD and oppositional defiance disorder to also have conduct disorder. I found that really interesting. The other one is intermittent explosive disorder, and this happens in short episodes that typically don't last more than an hour. In a way, I want you to think mood swings. When I see this, I'm thinking mood swings. And the hard part about it is it's not just something that they do, and then when they all of a sudden, like, it progresses for a long time. It's more like after that hour, all of a sudden they come out of it and they're happy-go-lucky, and you're kind of left sitting there going, I don't really understand. I don't know what to do with my hands right here. I don't. What just happened over the last hour? Don't know. But it is different from that, but is also the most diagnosed of all the externalized disorders. The last one is disruptive mood dysregulation disorder. And this is an antisocial disorder where it happens in episodes. And it seems like these people have an overreaction to different stimuli to which they aren't consistent. So let's just say, hey, you can't have any candy, kid. And then they just blow up out of nowhere, and it's like, "Rrr." But the difference between DD is that the kids, that they have this reaction, but when they come out of it, even though it might have been severe, there's remorse in it. But most of the time, people with DD, they're constantly in the state of irritability or anger or even sadness. Now, the last part of what we're going to talk about is substance disorder. So, with substance use disorder, let me back up just for 1 second here, because I want to make it specifically clear that when we're talking about these conduct disorders, it's important that we understand which one they are. Specifically because they do, all four have the different commonalities of it. What differs though is what is their almost like trigger or blow up point with that. And if we can identify which one of those it is, then we can start to progress on how we converse, how we treat the patient with those different symptoms. So now with addiction and substance use disorders, what's interesting about this is the DSM-5-TR lists four possible substance specifiers to use to denote or specify what the status of in relation to recovery would be for someone with addiction disorders. And they are in early remission, in sustained remission, on maintenance therapy, and in a controlled environment. Now, each substance is significant. So when we list these out, we have to say what it is that they're suffering from. So is that alcoholism? Are they suffering from methamphetamines? Are they cannabis users? We need to specify these things. And why should we specify them? Well, it goes back to similar with all the other disorders that we've talked about, is specifying them allows us as the clinicians to go in and specifically target and understand how we should treat a patient. And with addiction disorders, we do know that there are some people that may be a little bit more predisposed to have an addiction disorder. But a lot of time people with addiction disorders, it's not that they decided one day that, hey, they want to become addicted. I mean, most people with mental health disorders didn't decide, hey, I want to have that. But what's the difference about substance disorder is a lot of time it is something that is external, being a substance use or a substance that causes them to have a new disorder from there. And that's what makes it significantly different than a lot of the other pieces or a lot of the other disorders in the DSM-5-TR, is that it is a choice in regards to what the person uses. It may not be a choice of how their body reacts to it, but it is a choice that they made to use a substance. Now, that's most of the time. We do obviously have some people out there that didn't want to use it and was forced upon them, but for the most part, people choose to use it. So now, how do all of these, when we talk about sexual disorders and dysfunctions, body and gender dysphoria, conduct disorders, and substance abuse disorders, how they all fit to pieces, how they fit in here. I think a lot of it falls into this. So when we were watching in the follow-up documentary to the Overtaken documentary by Couch.Red entitled Overtaken 2, Where Are They Now? Tori DeGroot, who is this alumni coordinator for the Mission Pacific Coast Recovery, she speaks of a void in someone's heart that people need to fill. In this case, she's specifically talking about addictions, but I'm going to argue that in most cases, in conduct disorder, it's a little bit different, but when we start looking at sexual dysfunction and we start looking at addictions, well, we know pornography is an addiction there. When we start putting these pieces together, I think there's something significant to what she says, is there's something missing inside a person's heart. So I want to read real quick Ecclesiastes 3:11. In this is where King Solomon, as he writes this, he says, "He has made everything beautiful in its time. He has also set eternity in the human heart, yet no one can fathom what God has done from beginning to an end." There's a piece of our heart that God has created to know Him. And yet all throughout history, all throughout my life and everybody's life, we continuously try to fill in this void with something. And consistently, sadly, there are times that people, they open this void even further with trauma and other things. So we've looked all across the board at these different disorders. And so often when you read like what causes or what maybe is an outlier that we could also pinpoint in other youth maybe that might end up one day having schizophrenia or bipolar disorder, we see things like trauma. We see the same thing trauma-wise with people that become addicts, when people become sex addicts, when people end up having sexual dysfunction because of shame or whatever the case is, or maybe it's when they start looking into more of the paraphilia. The point is that there's a consistency here with all humanity, is when we try to fill a void in our hearts that was created by God, that only God can fill. significant things happen to us. I want to wrap up with one little piece because I know I've gone long here, but one thing is, my wife and I were actually talking about how interesting it is. People ask the question of why would God allow something like this to happen? And I'm going to argue that it's not that, obviously, it's not God that wanted these things to happen. I always say to my friends, or when I'm counseling, I always say, God is right there weeping with you. He didn't want for it to happen. He loves you, and he's weeping there with you. But what's interesting is as we went back to bipolar disorder, there was a point in there that I talked about children with trauma and how the trauma can actually change the genetic aspect to how a child grows up and how the part of their brain that initiates an understanding of their coping mechanisms, that it gets warped. And so they don't know how, their brain doesn't know how to cope. So when God tells us not to do X, Y, and Z, that it's bad for us, don't think it's just saying, hey man, it's just bad for you emotionally and blah, blah, blah. I think there's an actual part of that it's actually bad for our physical bodies, because he knows that if we encounter these little things, that our bodies don't work the way they're supposed to. It actually, in a way, makes it harder for us to fully know God when we've been a part of trauma, or when we've encountered shame and guilt or addiction or whatever the case is. It makes us harder to encounter God. Because now we're not coming to the forefront. We're not coming to this place of meeting him just being the creation that we are. We're coming to a place where we're meeting him with all this other baggage, and it's weighed us down for so long. So when I look at how can I, as going into this counseling field, really go in and start helping people, God created you with a void that only he can fill. We can continue going down this road of filling it with whatever the case it is, but it boils down to, until you get to the root of the problem, you're never going to really understand and establish what it is that you've tried so hard to fill the void with. If we can get to the root to it, we can stop it from growing. And when we remove that, the void that was created by God is now seen. And when we see it fully, then God can come in, clean it up, and restore it.